Welcome to the deep dive. Imagine a promising young horse, maybe you think it's a future champion, and suddenly it's showing these subtle signs of lameness or maybe a mysterious joint swelling.
Yeah, it's a scenario lots of owners face.
It really is, and it can be incredibly perplexing, can it?
Yeah.
We're talking about a developmental bone and cartilage disorder in young, growing horses, one that can really impact their health and athletic potential down the line.
That's right.
So today we're taking a deep dive into equine osteochondrosis, often just called OC, and its related condition, osteochondritis dissecans, or OCD.
And our mission here really is to get under the hood of this condition. We'll unpack what it actually is, look at the complex reasons it happens, how vets diagnose it, and what the treatment options look like.
Right.
And crucially, we'll also look at the different factors that kind of shape a horse's long-term outlook. It's not always straightforward.
Definitely. So whether you own horses, maybe you're studying to be a vet, or you're just fascinated by animal biology, you're about to get a much clearer picture of this really common but often misunderstood condition. Okay, let's start with the basics. Lay the foundation. Equine OC is classed as a developmental orthopedic disease, DOD, in growing horses. So when we say developmental, what exactly is developing improperly here? What's going on at that microscopic level?
Yeah, that's the perfect place to start because understanding the root cause is, well, it's key. Fundamentally, OC is a disturbance in this process called endochondral ossification.
Okay.
Think of it as the body's natural way of building bone, how bones get longer, how joints mature. Cartilage normally gets replaced by bone step by step.
I like a template.
Exactly. But in a horse with OC, this critical process goes a bit wrong. Instead of that cartilage turning into strong bone, you end up with these persistent areas of abnormal thickened cartilage.
Yeah.
And these areas are just weaker. They're vulnerable, kind of like a weak spot in pavement, making them prone to damage later on.
So a failure in that cartilage to bone transformation. And I understand this basic problem can show up in a couple of different ways in the joint. We hear about osteochondritis dissecans, OCD, and then subchondral bone cysts, SBCs. How are they different?
You're absolutely right. They stem from the same underlying issue, but look different. With OCD, osteochondritis dissecans, that abnormal cartilage can actually detach. It forms a flap or even a loose fragment inside the joint.
A loose bit floating around.
Yeah, sometimes with a little piece of underlying bone attached. Now, a subchondral bone cyst, an SBC, that's different. It's a fluid-filled lesion that forms underneath the cartilage surface.
Okay, so one's a fragment, one's a cyst underneath.
Exactly. And while both come from that same failure of endochondral ossification that retained cartilage, honestly, we don't fully understand why one spot develops a fragment and another develops a cyst. The theory is high motion areas might get more shear forces, leading to OCD flaps, while areas under more direct compression might be more prone to developing SBCs. But either way, it's the epiphyseal cartilage and the growing ends of the bones within the joint that are affected.
Okay, so that's the what. Now, this is where it gets really interesting, I think. OC is called a multifactorial disease. It's not just one thing causing it, which must be frustrating for owners. What makes it so complex?
It really is a puzzle, a complex interplay, like trying to balance several things at once. Multiple factors stack up, increasing the risk. First off, genetics. It plays a really significant role.
Right.
There's a clear genetic predisposition, but it's a polygenic trait, multiple genes involved, which explains why you can't just, eliminate it with one breeding decision.
So it's not simple inheritance.
Not at all. It's a persistent challenge for breeders. We definitely see higher rates in certain breeds, standardbreds, warm bloods, thoroughbreds, quarter horses. Research in Scandinavian standardbreds, for instance, shows pretty high heritability for hawk OC.
Okay, so genetics is a piece. But what about how we manage these young, fast-growing horses? Does that factor in?
Oh, absolutely. Rapid growth and nutrition are huge pieces of the puzzle. Foals on really high-calorie, high-carbohydrate diets, they're at increased risk.
Why is that?
Well, the body just can't keep pace. It can't ossify cartilage normally when growth is happening that fast. So avoiding overfeeding foals and yearlings is pretty crucial.
Good things.
And then you've got mineral imbalances. This is critical. Copper deficiency, for example, is strongly linked. Copper is essential for enzymes needed for collagen cross-linking, for building strong cartilage.
Like needing the right building blocks.
Exactly. Imagine trying to build a solid wall without enough mortar. It just won't be strong. Excess phosphorus can also contribute, especially if it's way out of whack relative to calcium. And too much zinc can actually interfere with copper absorption.
Wow, it's a delicate balance.
It really is. That calcium to phosphorus ratio, ideally around 1.5.1 to 2.1, it's a fine line. It really highlights why working with an equine nutritionist isn't just a nice to have, it's often essential.
Good point. What about protein? We used to hear a lot about that.
Yeah, historically people blamed high protein, but the evidence now suggests protein levels themselves are less consistently implicated than overall energy intake or those mineral imbalances we talked about.
Interesting how that thinking has changed. Okay, so genetics, nutrition.
Hmm.
What about physical factors?
Yes.
The actual stress on a joint while it's developing?
Spot on. Mechanical stress and trauma definitely play a role. And it's tricky because both too much exercise and not enough exercise can contribute to abnormal joint development.
So finding that middle ground.
Precisely. Consistent, moderate physical activity seems to be the most beneficial. There's also this idea of a time-dependent window of vulnerability for the growth cartilage. Specific stages of development are just more susceptible. And finally, hormonal imbalances have been suggested. Things like insulin, thyroid hormones, glucocorticoids. If they're abnormal, they could potentially interfere with bone metabolism. We know, for example, that giving long-term dexamethasone, a steroid, can actually induce OC-like lesions.
Right.
And we have to mention site vulnerability. Lesions tend to pop up in specific, predictable spots. Hock, stifle, fetlock, shoulder, even the neck vertebrae.
Why so spot?
They seem to experience higher stress, or maybe they have unique blood supply patterns. A common theory is a failure of the blood vessels to penetrate the cartilage properly in those specific areas during growth.
So it really isn't just one thing. It's this combination, genetics, diet, growth rate, exercise, maybe hormones, all interacting. That's a huge takeaway for anyone raising young horses, isn't it?
Absolutely. It's the combination that truly cranks up the risk, not usually one single culprit.
Given all that complexity, how do you even know if a horse might have OC? What are the key signs, the clues owners and vets should look for?
Well, that's where it gets really interesting, actually, because the signs can be quite subtle. Or sometimes there are no signs at all.
No signs.
Yeah, clinical signs typically show up in young horses, often between, say, 4 months and 2 years old, but sometimes you don't notice anything until they start training. And what's truly surprising is that many horses with OC lesions on x-rays are completely asymptomatic.
Wow.
The lesions only get discovered incidentally, maybe during a pre-purchase exam when someone's looking to buy the horse, or for insurance purposes.
So a horse could look perfectly fine, walk and trot sound, but still have these underlying issues. That's critical for people to understand, especially when buying horses.
Absolutely.
But when signs are present, what's the most common thing you'd see?
By far the most common sign is joint effusion, swelling. You might see it as a bog spavin, that's swelling in the hock, or maybe effusion in the stifle. And crucially, this swelling is usually not painful when you touch it, and it feels cool.
Okay, cool swelling, not like an infection.
Exactly. Lameness is another common sign, of course. It can vary a lot from really mild to quite moderate, occasionally severe. It might come and go or get worse with exercise.
So maybe noticeable only during or after work.
Often, yes. It might be absent when the horse is just resting in the stall and only become apparent when you ask for faster gaits or work them on circles. So a horse could look fine standing there, but then you put them under saddle and you notice something's off.
Right. Anything else an owner or trainer might pick up on?
Sometimes stiffness, a kind of reluctance to fully flex or extend the affected joint. They might also show pain on flexion tests where the vet holds the joint flexed for a period and then drops them off.
Okay.
And if the lameness has been going on for a while, if it's chronic, you might even see muscle atrophy, muscle wasting in that limb, like shoulder muscle loss with shoulder OC.
Makes sense if they're not using it properly.
Exactly. And then there's the more severe end of the spectrum. If OC affects the joints in the neck, the cervical vertebrae, it can actually lead to spinal cord compression.
Ah, Wobbler syndrome.
Precisely. That causes ataxia incoordination, that characteristic wobbly gait and proprioceptive deficits, meaning the horse has trouble knowing where its feet are.
The classic wobble.
Yeah.
So it's important to remember these signs vary a lot. And often it's just that non-painful joint swelling without obvious lameness, especially for OCD. But those cysts, the SBCs, they're more likely to cause pain and lameness.
That's generally true, yes. SBCs seem to cause more consistent lameness. And another key point, it's frequently bilateral, seen in both legs. Reports suggest 45% to 60% of cases affect both sides.
So always check the other leg.
Always. Good practice.
Okay, so if signs appear or maybe a lesion is found by chance on an x-ray, how do veterinarians really figure out what's going on? What's that diagnostic journey look like?
Well, the diagnostic journey usually kicks off with a really thorough clinical exam. That means watching the horse stand still, watching it move, walk, trot, maybe canter on straight lines, on circles, plus careful palpation, feeling all the joints and those limb flexion tests we mentioned.
Standard lameness workup.
Exactly. If lameness is seen, then diagnostic anesthesia nerve blocks or joint blocks can be super helpful. Injecting local anesthetic into a specific joint helps confirm if that joint is the source of the pain.
Numbing the area to pinpoint the problem.
Right. But the primary imaging tool, sort of the first line of investigation, is usually radiography, X-rays.
And what are vets looking for on those x-rays? What shows up?
On X-rays, we're looking for things like irregularities on the bone surface, maybe lucencies. Those are darker areas suggesting less bone density or a defect. We might see actual loose bone fragments, OCD fragments, or flattening of the joint surfaces, subchondral bone cysts, and sometimes sclerosis, which is increased bone density, like the bone reacting to the problem.
Seems like x-rays tell you a lot.
They do, but there are limitations. It's crucial to understand that early cartilage lesions, if there's no significant bone involvement yet, might be completely invisible on an X-ray.
So cartilage doesn't show up well.
Not directly, no. And maybe surprisingly, the radiographic findings don't always match the clinical signs. You can have a horse with really dramatic-looking lesions on X-ray that's perfectly sound, and vice versa.
Wow. That must complicate things.
It does, which is why it's also standard practice to X-ray the opposite limb, the contralateral joint, for comparison and to check for bilateral disease.
So if an x-ray doesn't give the full picture, especially with cartilage, what are the next steps? What other tools can dig deeper?
For getting really detailed images of the soft tissues, especially the cartilage itself, magnetic resonance imaging, or MRI, is considered the gold standard.
MRI.
It gives incredibly detailed pictures of the articular cartilage, any bone marrow edema or bruising, and surrounding soft tissues. MRI lets us spot those early lesions missed on X-rays and really precisely characterize OCD fragments, even if they're just cartilage with no bone, and map out those subchondral cysts.
Sounds ideal. What are the downsides?
Well, the main limitations are cost. MRI is expensive. And it usually requires general anesthesia, at least for the high-field machines that give the best images. Plus, availability is still somewhat limited compared to X-ray machines.
Right. And what about CT scans? We hear about those too.
Computed tomography, CT, yeah. CT is fantastic for detailed 3D assessment of the bone itself. It's great for complex cysts or finding very subtle bone fragments that might be hard to see clearly on a 2D X-ray. But it's less sensitive for looking directly at the cartilage compared to MRI.
So better for bone, MRI, better for cartilage?
Generally, yes. Ultrasonography can also play a role. It's mainly useful for assessing joint effusion, checking the fluid, and looking at the synovial membrane, the joint lining. It's not ideal for seeing the cartilage or bone surfaces deep inside the joint because sound waves don't penetrate bone well. You get acoustic shadowing.
They're useful sometimes.
Yeah, it can be particularly helpful for looking at the joints in the neck, the cervical, articular facets. And finally, there's nuclear scintigraphy, or a bone scan.
Bone scan, right.
This detects areas of increased burn activity or inflammation hotspots, which can be associated with OC lesions. It's really useful if you're trying to screen multiple joints at once, or if you have a subtle lameness and you're not sure exactly where it's coming from.
Like a whole body scan for problem areas.
Kind of, yeah, for the skeleton. And sometimes vets might do a synovial fluid analysis, take a sample of the joint fluid, maybe even culture it, mainly to rule out something like septic arthritis, a joint infection. Histology, looking at tissue samples microscopically, can also confirm retained cartilage.
Wow, it's quite an arsenal of tools. It's clear that vets really have to tailor the diagnostic approach, combining these techniques to get the most complete picture for each horse. It's like being a detective for every case.
It really is. You piece together the clues from the exam and the various imaging modalities.
So once you have that diagnosis, what does it actually mean for treatment? Given how varied OC can be, I'm guessing the approach depends on, well, a lot of factors.
It absolutely does. The treatment plan is highly individualized. It really depends on the type of lesion, its size, its location, whether the horse is actually lame or just has swelling, the horse's age, and importantly, what the horse is intended to do its future use.
Makes sense. What are the main paths?
Broadly, there are two main avenues. Conservative, meaning non-surgical management, and surgical management, usually arthroscopy.
Okay, let's talk conservative first. When is that typically chosen?
Conservative management is often the first choice for very young foals, say under 5 to 8 months old, because in some cases, especially at that age, some lesions might actually heal or resolve on their own over time.
Really? They can just disappear?
Sometimes, yes, or at least significantly improve. It's also an option for lesions found incidentally in horses that have no clinical signs, no lameness, no significant swelling. Or for mild cases, or sometimes based on the specific location, like certain types of Hawk OC lesions. You might try conservative management for 6 to 10 months in these young animals. Give them a chance.
And what does conservative management actually involve day to day for the owner?
It mainly involves managing their activity and diet. So, rest and controlled exercise are key. This might mean strict stall rest initially, or maybe turn out in a very small paddock, combined with controlled hand walking to reduce stress on the joints.
Less running around.
Right. But interestingly, some controlled light exercise can actually be beneficial for promoting cartilage health later on. For subchondral bone cysts, those SBCs, the restricted activity period might need to be longer, maybe 6 to 12 months.
Okay. And diet, you mentioned that earlier.
Diet is crucial in conservative management. The goal is often to lower the caloric density of the diet to slow down rapid growth without causing malnutrition, of course. This usually means reducing concentrates, the grain portion, and focusing on good quality forage, like hay.
Less energy going in.
Exactly, and ensuring balanced minerals is vital, especially making sure copper levels are adequate and that calcium to phosphorus ratio is correct, ideally that 1.5.1 to 2.1 range. This should really be based on analyzing the hay and maybe getting advice from a nutritionist. You'd want to avoid high-energy hays like straight alfalfa, too.
Got it. Are medications used conservatively?
Yes, systemic medications can be part of it. NSAIDs, nonsteroidal anti-inflammatories like firocoxib, phenylbutazone, flunixin can be used for managing pain and inflammation if needed. And then there are chondroprotectives, medications aimed at supporting joint health, things like injectable PS-JAGs, Equine is a common brand, or injectable hyaluronic acid like Legend. Oral joint supplements containing glucosamine, chondroitin, MSM are often used too, though the evidence for their effectiveness varies.
Okay, so rest, diet, maybe some meds. And then there's surgery. I think you said that's often the gold standard for more serious cases.
That's right. Surgical management, specifically arthroscopy, is really considered the gold standard for most OCD lesions that are clinically significant, meaning they're causing lameness or noticeable effusion, and often for subchondral bone cysts as well.
Arthroscopy, that's keyhole surgery, right?
Exactly. It's performed under general anesthesia. The surgeon makes tiny incisions and inserts a small camera, the arthroscope, and specialized instruments into the joint.
What's the goal during the surgery?
The main goals are to remove any loose OCD fragments, debride, or clean up damaged cartilage down to a healthy edge, and for cysts, to curette them, scrape out the lining and abnormal tissue. Sometimes the surgeon might place screws across the cyst or use bone grafts to help fill the defect and encourage healing.
Sounds quite precise. What are the advantages?
It's minimally invasive compared to opening the joint fully. It allows the surgeon to directly see the inside of the joint and the lesion, and generally the success rates for resolving lameness are quite high for many types of lesions.
What about after surgery? I imagine the recovery process is pretty important.
Oh, post-surgical rehabilitation is absolutely crucial. You can have a perfect surgery, but if the rehab isn't right, the outcome might not be optimal.
What does that typically involve?
It usually starts with a period of strict stall rest, maybe bandages on the joint. Then it's followed by a very gradual increase in controlled exercise. Things like hand walking, then maybe small paddock turnout, progressing to work like long lining or under saddle walking, all over several months.
A slow buildup.
A very slow, careful buildup. Sometimes adjunctive therapies are used alongside rehab, like cold therapy, icing, therapeutic laser, or shockwave therapy to help manage inflammation and potentially promote healing.
Okay. And what about injections directly into the joint? Are they used alongside these other approaches?
Yes, intra-articular injections have their place. Corticosteroids and hyaluronic acid can be injected into the joint to reduce inflammation and pain, maybe as a short-term measure if surgery isn't happening immediately or sometimes after surgery.
And those newer therapies?
Right, the biological or regenerative therapies. Things like PRP, platelet-rich plasma, or IRP interleukin-1 receptor antagonist protein, or APS autologous protein solution, and stem cell therapy. These can be injected into the joint or sometimes directly into lesions like cysts, with the aim of promoting better healing and reducing inflammation. They're often used as an adjunct to surgery or sometimes explored for chronic cases that haven't responded fully to other treatments.
It really sounds like the vet is putting together a custom playbook for each horse, considering all these options. That choice of treatment is clearly very individualized and really underscores why you need that expert veterinary consultation.
Absolutely. There's no single recipe. It's about tailoring the plan to the specific horse and lesion.
So after all that effort, whether it's months of careful conservative management or surgery and rehab, what's the actual outlook? This raises the big question, doesn't it? What can owners realistically expect for their horse's future, especially athletically?
That really is the million-dollar question, isn't it? And the honest answer is the prognosis varies widely. It can range from excellent to quite guarded.
What are the biggest factors influencing that outcome?
Several key things. The location of the lesion is paramount. Some locations just tend to do better than others.
For example,
Well, for instance, hock lesions, especially those common ones on the DRT, the distal intermediate ridge of the tibia, they generally have an excellent prognosis after surgical removal. We're talking 65% to maybe 90% of horses returning to their previous level of athletic activity.
that's pretty good.
It is. Stifle lesions on the lateral trochlear ridge, another common spot, often have a good to very good prognosis with surgery too. Many fetlock lesions also carry a good prognosis.
Okay, so hock stifle, fetlock often do well. Are there locations that are generally more worrying?
Yes, definitely. Shoulder lesions, for instance, tend to have a more guarded prognosis. Surgical access can be more challenging, and they often seem to cause persistent lameness even after treatment.
Right.
And as we mentioned, if OC affects the cervical vertebrae causing wobbler syndrome, the prognosis is usually guarded to poor. It really depends heavily on how severe the neurological signs are and whether surgery is successful in relieving the compression.
And what about the cysts, the SBCs?
Subchondral bone cysts are variable. Stifle SBCs, particularly those on the medial femoral condyle, the inside part of the thigh bone in the stifle, are notoriously challenging. They often carry a more guarded prognosis, especially for return to high-level athletic work.
So location is huge. What else plays a big role besides where the lesion is?
The severity of the lesion itself, naturally. Small, non-displaced fragments or just mild cartilage defects logically have a better prognosis than large fragments, significant cartilage damage, or cysts that are very large or deep.
Makes sense. Bigger problem, potentially tougher recovery.
Exactly. Also, whether the horse was showing clinical signs matters. Those asymptomatic lesions found by chance often have an excellent prognosis for future soundness. Horses that are clearly lame when diagnosed have a more guarded prognosis initially, but many still improve significantly with appropriate treatment.
Okay. Does the horse's age when treated make a difference?
Yes, age at treatment is important. Generally, treating these lesions in young horses, ideally before they enter intense training, often yields the best results. The cartilage in younger animals just seems to have a greater capacity for healing and remodeling. And remember, some lesions in those really young foals, under 5 to 8 months, might even resolve spontaneously.
Right. That potential for self-healing.
Exactly. Another factor is whether there's already significant osteoarthritis, degenerative joint disease, or DJD present in the joint. If arthritis is already established, the long-term prognosis for full athletic soundness becomes more guarded, even if the OC lesion itself is treated.
So secondary damage matters too.
It does. And finally, you have to consider the horse's intended job, the discipline and athletic goal. A horse destined for the demands of racing, high-level jumping, or dressage might face a more challenging prognosis with certain lesions compared to a horse intended for pleasure riding or breeding. The performance expectations are just different.
That makes perfect sense. It sounds like while OC is definitely a serious condition, the advancements, especially in arthroscopic surgery and maybe these newer regenerative therapies, have really improved the outcomes compared to, say, decades ago.
Oh, absolutely. Our ability to diagnose accurately and intervene effectively, particularly with arthroscopy, has made a massive difference.
And it really drives home that point about early detection, doesn't it? Finding these things through pre-purchase exams or routine x-rays of young horses seems critical for getting the best possible prognosis down the road.
Couldn't agree more. Early detection and intervention are key.
Well, we have truly taken a deep dive into equine osteochondrosis today. We've gone from the microscopic level, that endochondral ossification process, all the way to the real-world impact on horses and their careers. It's definitely a complex puzzle,
It is.
but it feels like one that we now have much better tools and understanding to approach and manage.
I think that's right. And this deep dive really reminds us that knowledge is most valuable when you can actually understand it and apply it. The insights we've discussed today really highlight how critically important early diagnosis and those individualized, tailored treatment plans are for these incredible animals.
Yeah.
It's all about giving them the best possible chance at a healthy, sound, athletic life.
So for you listening, here's a final thought to maybe chew on. Considering we know there are clear genetic links and we know how powerful early nutritional management can be, how might future breeding practices, maybe combined with advanced diagnostic screening, evolve? Could we actually start to minimize the incidence of OC in the next generation of horses, not just manage it?
That's the ultimate goal, isn't it?
It is, and maybe more broadly for all of us, what does this complex issue in horses tell us about that really delicate balance between rapid growth, nutrition, and physical stress on any developing body, whether it's animal or human? Something to think about.